then I will pull up some cases that we can all run through. And the cool thing about the cases that I'm pulling up is that they're readily available online. So it's not like these are copyrighted stuff. And like this study was very like open, very informal. I remember in med school, I learned best when I studied with people, and in residency, I kind of missed that. And all of our schedules are so different. So that's why I was like, let me just put this on social media, see who's interested. Okay, so let me share my screen. And what I was thinking is we can just run through a bunch of stroke cases for as long as, maybe for the next hour or two until we get tired. And then go from there. So I basically, what I did is I just Googled stroke cases, stroke case scenarios. And I came across some links. I kind of chose ones that are, more reliable than others. So I'll put these in the group chat so that in case we don't finish it, you guys can have this to access. And if there's topics that you guys want to do, or you guys were like, oh, we should do this from a case-based standpoint, just let me know and we can do it. Because it's all going to be on our boards or step 3. And one thing I'll make note of, Laura, because I'm firstly out of step 3 maybe like 2 years ago. So I remember like high yield stuff that really showed up on step 3, step 2, step 3. So I'll be sure to be like, oh, this is really high yield for me. So that, it gives you some high yield stuff as well. Okay, so this comes from like stroke.org. Is this from AHA? Yeah, this is from the American Heart and the American Stroke Association. Those two associations pretty much write the guidelines on stroke. So I was like, yeah, this sounds pretty reliable. So I'm just thinking we can just read through the cases together and kind of, figure out, just talk out loud and just kind of be like, okay, what are things we should be thinking of? If we see this patient in the emergency room, what are we going to do? How does that sound?
Love that.
Cool. So for this case, they say it's a 20-year-old man, no significant past medical history, presents to a primary stroke center with sudden left-sided weakness and imbalance, followed by a decreased level of consciousness. So sometimes that's all we get, when let's say I'm on call and the ED senior down in the ED is like, hey, I have this patient, 20-year-old male, left-sided weakness, I'm concerned for a stroke. So things that I'll be thinking about in my head is, number one, is this truly a stroke? Because, there are stroke mimics. And if it is a stroke, then what's the time window? What's their last known normal? Because if it's an acute stroke, two things I'm thinking is this patient a candidate for TPA or mechanical thrombectomy? So, things that I would want to know is what's this patient's last known normal. So they jump into the imaging. Oh, okay, well, we can just talk about it out loud. So, Laura, this is high yield for step exams, is really knowing the time window for being able to give TPA and mechanical thrombectomy. So, go ahead.
Back in the, I'm just thinking sort of back in my nursing days when I was nurse manager of neurosurgery or ICU. It was 3 hours, but that
you were a nurse?
Yeah, I was a nurse for 10 years. So I worked mainly neuro ICU, neurosurgery, neurostep down, ICU. So, but back then it was like, thank you. So back then it was 3 hours, but I think by now it's extended to 4.5 hours. Is that correct, guys?
Yeah.
Okay.
That's so cool. you're gonna match anywhere you want to go with that background alone. Oh, I can't wait until we do neuro ICU again because you're gonna be the expert in the neuro ICU since you since you spent 10 years in the ICU. Cool. So you're right. They just extended it to 4.5 hours. So guy wakes up, let's say he's within the time window, symptom onset was within 1 hour. He doesn't have any past medical history. Oh, so Laura, for you get this patient, you're in the emergency room, and the senior resident says, okay, please go see the patient, and then, present back to me. How would you go about doing the neuro exam?
So certainly he's got the decreased level of consciousness, so it's going to be particularly challenging to get information from him. So I would absolutely try to get collateral as best as possible. Whoever was around him, family, friends. At this point, I'm scavenging for numbers. Where is he coming from? Is he coming from a house? Is he coming from a bar? Is he coming from friends, girlfriend, boyfriend, whatever the case is? So immediately trying to get collateral, because I know from EMS services, they tend to give a lot of times it's a drop off. And so it's particularly challenging. So just trying to get as much information from collateral and EMS if possible. Yeah. Even just from EMS, where they found in the random park, or they even just location wise. So I would be definitely doing some hunting.
That is all great points. One thing I've learned in neurology is we really love details, and sometimes the localization lies in the details and the answer lies in the details. So being very detail oriented in neurology has been very key in my training. So you're right. If you can't get the information from the patient, you find a witness, you talk to family, you talk to EMS, you just talk to as many people as you need to get specific information. So the high yield information we're going to want in this gentleman. So we did we did a study group on high yield information we would want for a stroke standpoint. Oh, here it is. Let me find it, y'all. 1 second. Stroke. 1 second. Okay, I can't find it. Oh, well. Right, so you're right in that you want to get collateral. Gabriella, feel free to jump in. I'm just talking out loud here. Yeah, you want to get collateral. Biggest things we want to know is when's the patient's last known normal? And for me, I would do a focused neurological exam. Well, let's finish the history. What else would we want to know? When was his last known normal? Has he ever had this before? Does he really not have any other stroke risk factors, specifically like high blood pressure, diabetes, hyperlipidemia, irregular heart rate?
Any drug use?
Yep. Go ahead.
I would ask also for thinking that this is probably a stroke. We should ask him or his family for any contraindications to alteplase use. So, yeah.
If the patient has, what medications the patients are on, if any at all. It's just because he's 20, I'm just particularly concerned just from the age. Again, I'm really diving into not only the presentation at that current moment, but also is there anything else going on? Because this is not my classic, 55-year-old patient with, the cocktail of of past medical, like diabetes, hypertension, hyperlipidemia, and etc.
Exactly. And
And
so,
also,
go ahead.
no, go ahead. It's your time now.
Yeah, so some of the big things, contraindications would be, has the patient had, well, let's do absolute contraindications. Would be, has the patient been on any anticoagulation, like especially warfarin, and checking their INR? Do they have a history of head injury or any evidence of brain bleed? Looks like we have one person that's joining. I don't like this one. I'm going to find the TPA. Maybe find it before me. Feel free to share your screen. I want to find the contraindications directly from A.
So for the anticoagulations, had the patient been on, like, for example, like Coumadin, would it be more so of a relative contraindication because we can just kind of reverse that and then move forward from there?
I talked about this I think a week ago, and I haven't, Gabrielle, correct me if I'm wrong, I haven't seen people reverse then give because the risk of bleeding is so high. I think you want to know when did they last take the medication? And if they took it like yesterday, it's like no, sorry, because the risk. So I haven't seen it common practice in that let's reverse then give, because it takes time for the reversal agent to work, and by the time the patient is no longer therapeutic on their anticoagulant. I've never seen it, and I think it's that person's just going to bleed. So I don't think that's, but that's a good thought. Good point. Let me just pull up AHA. Oh, here it is.
Yeah.
So there's
We found
Go
it
ahead.
together. You
Cool.
can share yours.
Did you find? Okay, so I found the MDcalc. That's a reliable resource for contraindications to TPA, and this is high yield. I remember this coming up on my step 3 exam. So here, you get greater than 18. I know that they give, technically, it's greater than 18. I know some pediatric stroke docs give it to patients under 18, but I don't. That is like an attending level decision. So anywho, are you eligible? You have to be greater than 18. Concerns for an ischemic stroke. Time onset, like you said, lower, less than 4.5 hours. Now, here are absolute contraindications to TPA. We get CT head and we see hemorrhage on CT. Clinical presentation suggestive of a subarachnoid hemorrhage. Any neurosurgery or head trauma or stroke within the past 3 months. And that's because, concerns for hemorrhagic transformation or just worsening brain bleed. Uncontrolled hypertension. This showed up on my exam. The prompt was, patient comes in the window for TPA, which the following is a contraindication. Patient's blood pressure was like 190 over 100, and that was the answer. So make sure you have this committed to memory, 185 over 110, because they asked that multiple times, different ways in my lab exam. History of intracranial hemorrhage, known malformations, active internal bleeding, especially like GI or GU bleeding, no bleeding, diastasis, platelet counts less than, this is also my platelet count less than 100,000, patient received heparin, current oral anticoagulant use, INR greater than 1.7, or current use of a direct inhibitors. And blood glucose less than 50. Now, some of the relative contraindications are if the symptoms are rapidly improving, minor, major surgery, or non-head trauma within or in the previous 2 weeks, GI or UT hemorrhage within 21 days, seizure at stroke onset, a recent arterial puncture and non-compressible site. So, for example, if a patient had like femoral artery access because they had a stent placed. That's compressible, so you could still give TPA. But I'm going to talk about this with some colleagues. Some of the not compressible sites would be like if a patient just had a dialysis catheter placed, or if they had like a PICC line placed. Those are the things that you would want to be asking the patient. If they just had a lumbar puncture, you just punctured their CNS, you give them blood products, they could theoretically bleed. Post myocardial infarction pericarditis. This, I don't know why this is a contraindication. That's interesting.
Mhm.
Pregnancy, we all know we don't do things in pregnant females. And I've never heard of this, but additional warning signs to TPA, age greater than 80, history of prior stroke, diabetes. I don't know. I didn't know about this. Additional warnings. I wonder what that means. Oh, inclusion criteria. Any active anticoagulant use, even if NIH greater than 25. Interesting.
Yeah, I didn't know that one. I just feel like there's people that come in like, woof, like way off the charts with their NIH and like they're given TPA. So, and then, yeah, so that's a new one for me. Also for the blood pressure parameters. So, you have the contradiction of the systolic blood pressure and diastolic 185 over 110. So of course, like that's the contraindication. And then, my understanding is then you just address the blood pressure with like IV labetabol or IV nimodipine or whatever your facility uses. And then you like readdress and then provide the TPA once they meet the parameters. Okay, just want to check.
Oh yeah, great question.
I'm like
The same
seriously
with
going way back to
glucose.
my nursing days. So not way back actually, but
Yeah, and you do the same with glucose. If it's low, you can correct the glucose, and sometimes people get better, then you don't treat the possible stroke. But if it doesn't, then you can proceed with the TPA.
Okay, great.
Mhm.
Thank you.
And then, so for the last one, it says CT shows multilobular infarct, hypodensity. So I know that the reason why we don't want to give TPA if the infarct size is greater than 1/3 the cerebral hemisphere is because it's considered a large stroke, and the larger the stroke, the more likely it is to have hemorrhagic transformation. So if you're giving TPA on top of that, you're increasing the risk for the patient to bleed. So I know, so that's why we want to give it here, and that's why NIH greater than 25, because it probably means that the infarct is so huge. May want to. That's my thought.
But
that makes sense.
We also have to pay attention to the NIH Stroke Scale because for people who have a stroke in the left hemisphere, if they are aphasic, the NIH stroke is going to be bigger. Then in the right side, they're going to be like, they will have like neglect and they will understand everything. But on the left side, maybe the person had like a stroke that made the person aphasic, and the number will be higher because the person won't be able to comprehend some of the tasks. So this is something that we have to be aware of. The NIH stroke scales are usually higher in the left hemisphere.
Because the language area?
Yeah, because if the person doesn't comprehend the tasks, then they won't be able to do like index finger or to do all of the other things, answer the month, the year, look to the right and left, etc. So this is one thing that we have to be aware of regarding the NIH, and also that for posterior strokes, the NIH is not like for sometimes they stroke are really big and they cause big deficits, but the NIH stroke scale is not so big, so it doesn't access so well the posterior infarcts.
Since you brought up the NIH Stroke Scale, so this is anytime a patient comes in concerns for stroke, you want to do the NIH Stroke Scale. And the things that they include is, level of consciousness. Are they awake? Are they sleepy? Are they responsive? Or are they attended? And then the two questions you ask is what's their month and their age? Are they able to blink, squeezing? Are they able to follow commands? Horizontal arm movements, visual fields. You really only, looking for, is there any evidence of hemianopsia? Smile, is there any evidence of face asymmetry? And then based upon what you find, that's how you score it. And then you do strength testing in the upper extremities, lower extremities, and you just ask them to hold their hands up. And then you see, can they do it? They have to hold it for 10 seconds in the upper extremities, 5 seconds in the lower extremities. Then you just kind of grade and see what they can do. The limb ataxia is like the finger, the nose, heel, the shin. Sensory, you do a noxious stimuli in your hands and your feet, see if they respond. And then with the language, there's like a sheet that you show them the different objects and you have them point to it. They just changed it to make it more, to make it less offensive and less sexist, because the old stroke cards were like all the females in the kitchen washing the dishes, like it's very just rooted in very stereotypical roles that males and females supposedly play in the U.S. So they recently updated it to where it's more inclusive. So I thought, okay, good for them. They still have a long way to go, but I just heard that they updated the stroke cards.
Do you mind actually, because I'm used to that picture and the kid in the cookie jar and the mom washing dishes and the water flowing over.
Yeah.
Can you pull up the new picture? That I would love to see that.
I'm also curious. I didn't know they had changed it.
Yeah, this is interesting. I'm wondering if the hospitals are actually up to date with this new picture.
Let me see if I can find a publication. Maybe on the NIH Stroke website. Let's see. No, it doesn't look like the main website. Let me find the article real quick. Yeah, it was one of my colleagues that told me about it. I was like, what? Because he's like, I know you're really interested in disparities. You'd be really excited to hear this news. I'm like, what? It's about time. Okay, let's see. Stroke. Let me find it. Okay, when I find it, I'll send it to you. I can't find it. No. Oh, okay, I found it. Okay, I'll pull it up. Okay, here it is. Stealing cookies in the 21st century. Measures of spoken narrative in healthy versus speakers with aphasia. So let's see what image they use. See what they use, the man! And out in the yard mowing the grass. I'm like, it's about time.
And they added a dog.
Oh, they did.
They did. That's a great observation. You're not a phasic.
Right. Let's see. Oh, and they added. Oh, look, multiracial family. I love. So it's like, did they add multi? I love it. See, I'll send you guys this.
That is great.
Can you send the link for us, please?
Yeah, I'm gonna do this right now. So I'm like, it is about time. And they should also update those optics. I don't know what a hammock is.
Yeah.
I mean, that's not like part of like the, like not everybody knows what a hammock is.
I love the glove / hand. That always.
That's so funny.
Thanks.
No problem. Okay, so let me call this over here. Okay, so I'm trying to think. So, time window, contraindications to TPA, talk to other bystanders who may witness the event. So, sounds like so far, if he has left-sided weakness, we would score him for weakness on the left side and balance. Always another thing to note, we don't ask patients to get up and walk with the stroke scale. So that's something that I've been taught to always do. Even though we don't score it, you always want to ask the patients to get up and walk, because that tells you a lot with respect to their deficits. So imbalance followed by decreased level of consciousness. So then we would score him for alertness as well. And so pretty much then we just get a CT head to see if he has any evidence of bleed. That's the main reason why to get the CT head, is to see, is this guy bleeding? Because if he is, roll TPA off the table. And then the CT head can also show us some other things as well. So let's go scroll down. So the other thing that I learned is really using our exam to help us look at help us look at the CT head. So we know that he has left-sided weakness, so that will localize to the right side. So we would probably, I would be looking at the right cerebral hemisphere. He also has some imbalance. So it could be due to his weakness, or he could have, like ataxia, depending on how his gait looks. So then you maybe look, does he have something going on in the cerebellum? He also has decreased level of consciousness. That'd be more so a global process for a decreased level of consciousness. That's more, it doesn't like really localize to like a specific hemisphere. You would have to hit like, I think the thalamus bilaterally, and the parts of like the brainstem with the reticulating activating system to get, to hit, what's this called? Consciousness.
In the pons, right?
Oh, in pons? Okay. Yeah, there's 4 places that if you hit, then that can cause coma, maybe not so much reduced level of consciousness.
Yeah, one thing that I wanted to add for this person, like he's young and he's having a stroke, and one thing that we have to think about that's not going to change the treatment right now, but is artery dissection, which is a cause of stroke in young people.
Oh, that's a good one. That's a good point. So arterial dissection, like in the
vertebral, like maybe, or
yeah, in this case it would be vertebral, but if we didn't know how to localize it before, we had like to think about carotid dissection. I think it's more common than vertebral dissection or basilar dissection.
Oh, so which one's more common? Like what part is more common? Like this kind of.
Yeah, I'm not sure, but I think carotid dissection is more common comparing to the posterior arteries dissection. But I'm just guessing.
I see.
Not sure.
But that would be on your differential because he's so young.
Yeah. For a stroke in a young person, we have to think about artery dissection. Especially if the person doesn't have any risk factors. We don't know about him, right? But the classic ones like hypertension, diabetes, obesity, and so on, dyslipidemia.
I like that. I was also even, and now just looking at the presentation, I definitely, I see that I see how that could definitely make sense. I was also even thinking like, just a young person, like, I don't know, maybe hypercoagulable states, something in that nature, factor 5 or something. Yeah, now just thinking about like the imbalance and like and stuff that definitely, I can see that as a differential for sure.
Mhm.
See, this is what I think stuff like this is helpful, because now when I go to the emergency room and I see someone who's young, I'll be like, oh, I didn't remember to think about dissections. Cool. So now we have his CT head, and the biggest reason we're doing CT is to rule out hemorrhage. Hemorrhage are they're hypodense on CT. Lord, key to note for step 2, step 3, they love. Make sure you know how epidural hematomas, subarachs, subdural hematomas, or hemorrhage, and intraventricular hemorrhage look like, because they love asking those questions.
Like the lens shape with the epidurals, and the crescent shape with the subdurals, and the spidery with the subarachnoids.
Yeah.
Perfect.
So because he's having left-sided symptoms, we will first focus and look to see if he has anything on the right side. And some of the changes infarct on CT scan includes the blurring of the gray white matter region. So you see down here where you can really see the white matter really nicely in the cerebellum. You can see the gray matter. What happens in stroke is that the lines become very blurry, and it's hard to tease out gray versus white. So that's one big thing you're looking for. Areas of hypodensity. Looks like they might be pointing out the hypodense basilar artery. Sometimes what you'll see in an acute stroke is where you see the MCA coming off here on the side, feeding the cortex. You'll see it very hyperdense, and they call it a hyperdense MCA sign. And sometimes you'll see that in acute stroke, and it can be pathognomonic for MCA occlusion. But sometimes it can just be bright because patient is old and all their blood vessels are calcified. So, but I think the biggest thing to know in the CT, because sometimes you want to ask you is why, especially when you're round, you get it because you're going to rule out a bleed. But it's not really used to diagnose a stroke. I mean, you can see a stroke, but that's not the main go-to image for stroke. So you're really just making sure you're not seeing a huge whopping brain bleed. And then after that, if we don't see anything on CT, then it's like, okay, we can, and patient doesn't have any contraindications of getting TPA, you can, push TPA. Do you wait, Gabriella, for the CTA head and neck to come back before you push TPA, or do you just like CT head, no brain bleed, patient has given consent, glucose is normal, blood pressure is normal, boom, I'm giving TPA?
Yeah, good question. I think this will depend on the protocol of the hospital.
That's true.
Where I did my residency here in Brazil, since most of the times we couldn't leave the emergency room with the medication because of organizational reasons. It was possible, but it was harder because a nurse would have to come with us to the CT scan, and the person would have to leave the emergency department, which didn't have the necessary amount of staff that would require to stay there. So we would do all together the CT and CTA, and then come back to the emergency department and do the TPA. But I think it would be better to, if possible, to do right after this CT scan, right? The faster, the better.
That's
How do you do it in where you practice?
So,
and I would love to hear Laura.
Yeah. So I haven't pushed by myself TPA. It's done at the fourth year. I feel like everything just kind of gets done at the same time. You know, CT head gets done, and CT head's really always ordered with CT head and neck, and then the TPA. So from what I've seen, it's all done at the same time. But I guess from the guidelines, you know, you don't want to delay given the TPA once you know the patient meets the criteria for the CPA. So I can understand not waiting for the CT head and neck. But like, yeah, that's a good point. Whatever, just know what the hospital protocol is.
Yeah, you know, just from sort of like my background, it actually ties right along with the both of you. Just it was definitely very protocol driven by the hospital, and this was at a comprehensive stroke unit or program. And, it was definitely non-contrast CT and push TPA. You know, however, to your point, if there was a very, 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 very high suspicion. In this case, I think there's reason to maybe like throw in the CTA just because he's 20. I mean, he's 20. He's not the 65-year-old that's had 3 heart attacks and 20 stents.
Yeah, so, that's a good point.
You know, so I think, and I'm just being dramatic there, but you know, I think this would be, I could imagine a neurologist saying, you know, let's do a CTA really quickly, you know.
Yeah. That makes sense.
Yeah, so I will say, just because I'm sort of like the baby student here, as far as CTs are concerned, I haven't done, I'm finishing up my 3rd year, so I haven't done a radiology elective. So a lot of my information, also I tune into some neurology podcasts, and I thought it was interesting as far as mnemonic to tackling CTs and how to like read them. So I then like, based on this neurology podcast, it was like, look for the 3 H's: hemorrhage, hydrocephalus, and herniation. Those are the big ones. Is there something else that you guys use to sort of like really, because radiology is like, it's a new thing for me, you know?
Yeah, remind me. So I'm huge on podcasts and YouTube. So there's this really cool, what's his name? YouTube radiologist. What's his name? Maybe I have it saved.
I listen to neurology podcasts, Neurology Minutes, and then just this random other neurology, which is more for like a clinical guideline, and neurology exam prep. Is there one that I'm missing that I need to listen to?
There's this one that this guy. He is so good. Have you watched his stuff? I pretty much.
Yeah.
I'll send, what's his name? Let me show you the name. This guy from Rutgers, I listen, he has so many different, I believe he's stroke trained. So many different videos that really walk you through how to read imaging. That's where, because I was the same way. I was like, I don't know what, but I binge watched this stuff multiple times. And he has one on like all important like imaging sequences, and he even has one on stroke, and that, you know, teaches you like the high yield things to read, look out for when it teaches you how to like walk you through what am I looking for from a stroke standpoint on a CT, MRI, DWI, ADC. So I put this in the group chat. I would recommend his stuff. He's really good.
Thank you.
Yeah, no problem. So, talk about the CT, and then now, so the reason we get the CTA head and neck is to look for large vessel occlusion, really looking in the carotids and the anterior circulation and the posterior circulation, seeing if there's any evidence of large vessel occlusion, because if there is and it's very proximal, then we can call the surgeons to come in and do mechanical thrombectomies to relieve the clot. So that's one of the big reasons to get the CTA, so look for large vessel occlusion. So let's see what they say here. CT angioceros meant by basilar occlusion. So this is something that, from what I've seen, it's a difficult area to retrieve because it's in a very sensitive. I mean, that's your brainstem. You know, your basilar artery feeds your brainstem, and if you go in there and shower a clot or dissect, the person's dead.
Yeah.
So I haven't seen a lot of surgeons really go for the basilar, but the protocol or standard of care is if it's in like the proximal, M1 or like an M2 branch, then they go for mechanical thrombectomy. So let's see what they did. So I give him TPA. That makes sense. So it looks like he was at outside hospital where he was at a comprehensive stroke center. So they give him TPA, then they transfer him to a comprehensive stroke center. They do the CTA head and neck that shows the basilar occlusion. Oh, so he underwent mechanical thrombectomy. Wow.
They went for it.
Wow. I guess we do it sometimes. So this really isn't high yield for step 2 or step 3, but in neurology, knowing the circle of Willis on imaging is high yield. So this would be the basilar, and then here you have the oh my god, I'm like
the vertebrals.
Yeah, and then as we go up here, this is like the posterior circulation. This should be don't tell me, guys. Let me think of this. This is PCA?
No, it should be the PCOM, or sorry.
Yes.
So I thought that would be the P. No,
I
I
got
think that's PCOM, isn't it? Or oh boy, I have to look.
I don't know. I'm the worst.
So I know that this is
in geography.
Basilar. I feel that this is the posterior circulating, and this is the superior cerebellar, and then we have what comes off. So we have superior, then we have inferior. Oh yes, I used to know this. Let me pull this up. Circle.
So I think I want to actually say that was the PCOM though.
The PCOM? Oh no, the PCOM. Okay, let me pull it up.
And then the MCAs come.
If you type in geography after that or angiogram, there are some images with like the same image that we're trying to see, like this one. I'm sending in the chat.
Okay, awesome.
Then we can compare with the other one. Try to
nice
geography vision.
Nice.
Okay, it's a PCA. You're right there. Okay.
So yeah, it's the PCA.
Okay.
So let's
the PCA then directly comes off of the basilar then. Okay.
Let me see like an annotate. I used to be able to annotate on this. Okay, so PCA, then we have the basilar, and this is the superior cerebellar, and then we have the interior, inferior cerebellar arteries that come off the basilar, and then the posterior, inferior cerebellar artery comes off the vertebrals. Okay. So then, let's go back here.
Yeah, I think we can see all of them here, right?
So this would be P, posterior cerebellar artery. This would be superior cerebral.
Or posterior.
Cerebellar?
Is that so? That's PCA you're saying?
So this here is PCA.
Okay, then
I think
so then
superior cerebellar artery.
right. Then the bottom one would have to be superior cerebellar artery, right?
Awesome. Yeah. And then
Superior
here,
and superior, like they're close.
so posterior cerebral artery, and then superior cerebellar artery. Then we have the basilar artery. Then we have the vertebral artery. And then let's see. So what comes off? Well, it should be maybe here would be the ACAs. Or sorry,
I A.
ACA.
Yeah, I can. Mhm.
And then pica comes off the vertebral, so maybe
Mhm.
PICA. Okay. And so his clot was in the
Yeah,
basilar artery,
yeah.
and let's see what it says. His exam improved. Oh, so let's try and map. So if I hate the brainstem. So if he had left-sided weakness and a imbalance and impaired level of consciousness, so we can understand why he had the impaired level of consciousness because basilar pons, like Gabriella said earlier, that there's like
That like RAS system.
the reticular activating system. Is that in the pons or is that in the midbrain?
It's actually in the pons, like Gabrielle was saying.
Oh, okay. Make note
That's where you get like the posturing too, right? Am I correct or?
The what?
The posturing, like the cerebral decorticate, or no? Yikes!
I don't remember. I don't know.
I think that's also part of it, I believe.
Is that what the red nucleus is?
Yes, yeah, exactly.
Okay.
Exactly. But I know like Basilar though is one of those where you get like the locked in syndrome, meaning you only get
Yes, you're right. Yep.
vertebral eye motion.
Yep.
Not
You're
vertebral,
right.
I'm sorry, vertical. Jeez. Not vertical. Horizontal eye movement.
Yeah, you're right. So now we know why he had decreased level of consciousness. Left-sided weakness. You guys, I don't like the pons. I hate the brainstem localization. So
Have you heard of the rule of 4 of the brainstem?
I've heard it, but it's always hard for me to remember it. But please teach. I'm taking notes. I hate the brainstem.
Okay, so I don't remember the whole rule of 4, but I can send the article for you later. But in this case, let's try to organize what he's saying. So this person has left-sided weakness. So it's the motor area. So if it's motor, the M indicates that it's a medial lesion, right? So it's not lateral.
Okay.
And we know it's in the brainstem. So medial in the brainstem, it's probably the basilar artery. But okay, so we have if there is a motor like weakness, I think it's probably medial. And loss of balance. Oh my gosh, I don't remember. I just read this article again, like 1 month ago. I'm gonna find the article and send to you, and try to organize my thoughts and explain that to you.
Thank you. So we'll come back to his local. At least we know why he had reduced level of consciousness. We got that. His imbalance that was localized to the cerebellum.
Gabrielle, were you referring to the rule of 4s just now?
Yeah.
That's like clutch, and that brings me way back. And I actually have like a screenshot. Like I guess I could maybe. Like hold on, let me see.
Okay.
So let me see if I can. I don't know if this will work.
Do you know Do you know how to share your screen?
Oh, this is on my iPad. So I'm like, you know what? If you type in rule of fours, it will literally break it down, like literally just the way Gabrielle was saying. Like, so you have the brainstem and you organize it in such a way where you have midbrain, pons, medulla, and then you put like.
Oh, did you send something in the chat? Someone, okay.
I sent the article, the original article, but I don't remember how to explain. I do remember that you have to organize between medial and lateral,
Right.
and I feel the motor.
It's complex. It's definitely complex, and like you're saying, the medial and so you have like lateral and you have medial, and you organize it in the midbrain as column 1, pons column 2, and medulla column 3. And so you put the medial cranial nerves in the middle, and those will be like the motor, like you were mentioning. And basically you put cranial nerves 3 and 4 into the midbrain in the medial area, 6, and it gets complex. I think it's better if you just like read it, because it gets crazy. Sorry. But like the lateral is going to be PCA in the midbrains, AICA in the pons, and then pica in the medulla, and then basilar would be in the pons, and then ASA in the medulla. It gets super complex, but oh, there it is. Yeah, so MM, like you have the motor, you have the medial lemniscus, medial MLF, motor nucleus. Yeah, and all of the M's are for medial. So like that's why it makes perfect sense. What Gabrielle's saying is the reason why he's having motor symptoms, not sensory. Sensory will be on the lateral
side, sensory side. Yeah, that's it.
Right? Like, thanks. Oh my God.
And spinal cerebellar is also side.
Spinothalamic, it's all the S's. It's the S's.
So spinal is side.
So all the S's are for lateral, all the M's like motor, medial lemniscus, MLF, and motor, like that's all medial. And then all the S's that you see here, spinal, cerebellar, spinothalamic, sensory, those are all lateral.
Oh, I see. So because we had and this is for the brainstem.
It's so you break the brainstem into its 3 components. So starting from, you have the midbrain, pons, and medulla. And then if you remember way back, I'm sure, remember there's cranial nerves specific to each of those anatomical structures. So even though cranial nerve 1 and 2, we kind of they're not actually part of the brainstem, but it's like, but just kind of put it as like, for each component, for each 3, so midbrain, pons, medulla, there's 4 cranial nerves. 1 through 4 is midbrain, 5 through 8 is pons, and then 9 through 12 is that? Yeah, 9 through 12 is medulla. So 4, 4, and 4. But remember, in order to make the rules apply, you just remember though, 1 and 2 are not actually in the brain, but just to make it 4, 4, and 4. And at that point now, to break down which cranial nerves are in the medial, medial, that's when whichever ones are divisible into 12, it gets crazy. So what's divisible into 12? Well, cranial nerve 3 is divisible into 12. Cranial number 4, 3 and 4 are divisible into 12. So stick that into the medial, right? So then for pons, remember pons is going to be 5 through 8. So what's divisible into 12 in those cranial nerves? 5 is 5 divisible into 12? No. 6, yes. So 6 is going to be medial. Is 7 divisible?
Yes. No.
7 is not. You have a PhD in MD. Is 8 divisible into 12? No.
Or calculator.
So far we have midbrain medial, which is 3 and 4. We have pons, which is 6. And remember, so now we're going to go to medulla. Medulla cranial nerves is 9 through 12. Is 9 divisible into 12? No. Is 10? No. Is 11? No. Is 12? Yes.
Yes.
So our medial nerves are what? 3, 4, 6,
and 12.
3, 4, 6, 12 medial nerves.
Right. So then everything else is lateral.
Oh, okay. Then everything else is lateral.
And then to piggyback off again what Gabrielle was saying, the medial, think medial, everything that starts with an M. So medial is going to be motor, medial lemniscus, medial longitudinal fasciculus, motor nucleus and nerve. And then everything, all the cranial nerves in those brainstem structures that we mentioned that are lateral, that are part of that structure, they're going to be the S's, the sensory, the sympathetic, the spinothalamic, so pain and temperature there, spinocerebellar, like the imbalance. So those are lateral. And then to break down, okay, now what arteries are in medial and what arteries are in lateral, then that's kind of separate, that's a separate thing. So it's going to be from top to bottom, it's going to be lateral is going to be PCA, ICA, PICA.
PCA, you said PCA?
ICA and then PICA. So
ICA.
PCA, ICA, PICA, and PCA correlates with midbrain, ICA correlates with pons, PICA correlates with medulla. These are lateral arteries.
Okay.
This patient is affected medially. Remember we said like the mid, yeah. So medial,
okay, yeah, you're right. Mm-hmm.
So for medial arteries, there's going to be nothing in the midbrain. There's going to be basilar for the pons, and then there's going to be the ASA for the anterior spinal artery for the medulla. So
okay,
that's the breakdown of the arteries, medial and lateral.
I see. So you said the anterior spinal artery is lateral?
No, medial.
Oh, medial for the medulla.
For the medulla, correct.
What is lateral for the medulla?
Lateral for medulla is going to be PICA.
PICA.
Yeah. So again, lateral top to bottom is going to be PCA, ICA, PICA, correlating with midbrain, pons, medulla. Medial arteries for midbrain, pons, medulla is going to be nothing for midbrain, basilar for pons, ASA for medulla.
Oh, okay. And then medial.
So those are that's like the rule of fours, and the rule of fours include again, remembering the cranial nerves, there's 12, 4 in each anatomic structure. Whatever's divisible into 12 is medial. Whatever's not divisible into 12 is lateral. And so then you make those correlations with the clinical picture.
Okay, so for him, he has left-sided weakness. So that means
motor, right?
Motor.
So motor medial.
Okay, motor medial. And this is just for the brainstem localization.
Correct. This only is applicable for brainstem. Correct.
I see.
But we've identified that it's a brainstem issue because we said basilar, which is in the pons. So,
I see.
And specifically medial pons.
Oh, okay. So medial pons. And then, so then how can we explain his imbalance with with the basilar artery?
Well, see, here's the tricky part. Decreased level of consciousness. So, of course, right?
Don't the, how do you call it? Don't the peduncles, the cerebellar peduncles, isn't that in the pons area, and they give tracts into the cerebellum? Yeah, I think that's how we explain it. Hold on.
But I think the loss of balance for him is probably has multiple causes. Like Laura said, he has a decreased level of consciousness, and he also has a left-sided weakness, and the person did not specify if he wasn't balanced because of the weakness.
That's true. That's true.
We would expect, since this is a problem, is it in the pons? No, or midbrain?
Oh, yeah. Why did we?
Laura, what did you say Basilar was?
So basilar is in the medial, is located in the pons. The basilar artery is located in the pons.
So we also would expect a 6 cranial nerve palsy. Is that correct?
Correct. That's correct. Right. And again, it also is all relative, how significant of an infarct, but you're completely correct. on that, yes. So like the
Thank you
lateral
so
rectus
much.
of the eyes, I guess, like there's like a forced deviation or something.
Mm-hmm.
It's been helpful. You guys, I don't like the brainstem, but now I dislike it a little bit less because of this.
Yeah, thanks so much for explaining, Laura.
I'm actually really upset at Mayo Clinic because I feel like the rule of fours is so clutch. Like you can sound so smart about brainstem, and it's really just rule of fours. It's just memorizing lateral medial for the arteries in the 3 different components and then the cranial nerves. Shameful, Mayo.
Oh, I'm sure they taught me. It just goes in one ear and sometimes goes out the other. Oh, hey, but you put it back in. See, as long as it gets back in there. Oh, thank you for that. I'll have to keep practicing that. Hopefully that will come up again.
Thank you for bringing that up, though. I actually totally forgot about the rule of fours for a split second, and I was like, "That's what you're saying." So thank you for that.
Thank you for explaining. Now I think I understood. Let's see how much time it will last.
Awesome. So now we're on to case 2, 62-year-old female. Now this female has hypertension, hyperlipidemia, presents to a primary stroke center. She has sudden onset of weakness on the right side. Exam, she has global aphasia, left gaze preference, right homonymous hemianopsia, right facial droop, dysarthria, and right hemiplegia. So with those symptoms alone, let's localize. So weakness on the right side, that's left brain or left cortex. Global aphasia, so let's assume she's right-handed, that would be left side. She has left gaze preference, so it's kind of neglect. So hemi-neglect, that's like the non-dominant. Non-dominant parietal?
That is correct. Which is usually in the right lobe.
Okay, but all her symptoms, so far we said we're on the left side. So why does she have a left gaze preference?
Because she probably has a problem with the right frontal eye field, eye control of movements.
Okay,
frontal lobes, they also control the gaze preference.
Oh,
probably not because of neglect, but probably because of the she's not able to perform the horizontal gaze to the right.
So then if she prefers the left, that means which eye fields is it the right eye fields? So how do I know which eye field is problematic?
Well, the thing is, she does have the right homonymous hemianopsia, so that would still make it left, though, correct? Because it would.
Oh, yes.
Yeah.
Yeah, so I don't know how to explain that, the left gaze. I thought it was going to localize to the frontal eye field, but yeah. But her stroke is in the left because of the other symptoms, right?
Supranuclear lesion. So I'm kind of wondering if there's.
Oh, you were right, Gabriella. It says involves right frontal lobe, so I could localize to the right frontal lobe, but maybe. But so far, all her symptoms are localizing to the left. Are we missing something? Let's see what AHA has to say. Horizontal gaze, blah, blah, blah. Originates frontal lobes.
Maybe oh, no. I have to think before saying. Sorry, go ahead.
I'm just skimming through this. Me pursue, blah, blah, blah. Okay, an acute defective lesion along the right frontal lobe will cause left hemiparesis with left gaze palsy. But she has right-sided symptoms, right?
Mm-hmm.
Okay, so maybe something else is causing her gaze preference. But who knows? Maybe she has an old stroke. But at least when like you said, Gabriella, it could localize to the right side of the brain. So we'll just see if they explain why she has right-sided rights on the right. Okay, and then the right anomalous hemianopsia, that localizes to the left occipital lobe. So far, this lady sounds like she has occipital lobe involvement. She has temporal lobe, parietal, and MCA involvement. So she has at least MCA territory because of the right-sided weakness, but we don't know if it's her arm or her leg, so it could be MCA or ACA. The right homonymous hemianopsia is PCA. Her speech is MCA, so multi-distributions are involved. And then she has right hemiplegia. Again, it doesn't say if it's leg or arm. So she has a high NIH Stroke Scale. CT head unequivocal for hypodensity in the left middle cerebral artery. So let's go to that. So here's the CT head. And then, so because she's having right-sided symptoms, we want to look to the left. And then here, looks like they're showing the occlusion. Is that what they're showing in the MCA distribution?
I think so.
Yeah, CT shows left MCA occlusion. Oh, looks like they also showed maybe some hypodens in the left MCA. I can't see it. Cool. She was given TPA in 2 hours from symptom onset. And transferred. Go ahead.
So she was a drip and ship.
Yeah.
She was what?
Drip and ship. So it's a term they use here in the U.S. where, because I think the rule is the EMS have to go to the nearest emergency room. And patients, if they get TPA but it's not a comprehensive stroke center, then it's like drip. You give them TPA and then you ship them off, like drip and ship. It's a funny term.
The nearest hospital.
Thanks for teaching me that.
If I'm not confused, if I'm not mistaken, though, I believe it's not only does EMS have to, EMS has to bring them to the nearest primary stroke, or
okay.
If you bring them to just a regular hospital that's not primary or comprehensive, then that will delay care because they can't give alteplase. So now we're just in a random ER that really can't do anything but a CT. So my understanding EMS has to find either the nearest primary or comprehensive, and being that most cities have more primary than comprehensive, you can anticipate that to be a very common theme of drip and ships, because many community hospitals are primary stroke certified, but then you have these big dogs that are comprehensive, and there's not necessarily all these big, hospitals.
I see. Thank you. I didn't know that there were primary stroke centers. I just thought either you're comprehensive or you're not. And I just assumed that all EDs can get TPA, but
that's absolutely incorrect. You must. And I promise you, I only know this because I was nurse manager of neurosurgery. So I promise you, it's only, and so it's specific. They will bypass a hospital that is not primary stroke certified if they suspect that it's a stroke. If EMS, if they have called a code stroke, then immediately they'll go to the nearest primary stroke certified.
I see.
many of the community hospitals are primary, and there's a lot more primaries than comprehensive. So
I see. Oh, thank you for teaching me. This is why I love this study group, you know, because it's like we all learn from each other. Beautiful. So she was giving TPA, transferred to a stroke center, where digital subtraction angiography confirmed left middle cerebral artery occlusion. Let's go down. So, okay, y'all want to practice our blood vessels? Okay, let's practice.
I knew you'd do this, and I was like, no.
no, this one's a little bit tricky.
We can do it. We can do it. Let me get out my drawing. Okay, so we know this is the internal carotid. And then we go here, and then we go here. So what do we think?
MCA? So
Awesome. Very good. And then
the ACA's up there going, oh, no.
Good.
Well, then
Yeah.
Yeah. Mm-hmm.
both ACAs, and then you can assume that there's the ACOM. And then what do you think's on this side?
Just the MCA as well.
Awesome. And then you can see here how it branches. I forget which one's M1, but like there's an M1, M2 branch. Awesome. Nice job. And let's see. So this is a different view. So here we have the internal carotids. This looks like ACA stuff. This might be. It's like a side view of the brain. I think this one going back here is MCA. Let's look it up. What do you guys think?
The arrow is pointing to the empty MCA. Is that correct?
That's my guess.
Yeah, like it's
Okay.
pointing to the
It makes
occlusion.
sense.
So
Thanks.
And then here, yeah, I don't know what's going on here.
wait, if you make that quick
It's
U-turn
after.
there, I think wouldn't that be the MCA, right? Like the bigger, well, so like the
This one?
yeah, wouldn't that or
Yeah,
just-
I think so.
and then the other, yeah, right there, and then if you take the quick left there, like that just follows, yeah, like wouldn't that be MCA-ish or?
Sounds good. Yeah. I wonder what like view this is, because this one looks like coronal. This one looks like a sagittal. I don't know what this one looks like, but cool. Awesome. We got the main arteries. So now we go back here. Given TPA, blah, blah, blah. Underwent mechanical thrombectomy with recanalization of MCA figure 5 on slide 9. Did we see that already? Okay, we saw that. Cool. The next day, she only had very mild expressive aphasia and right facial droop. Beautiful. Awesome.
Oh,
So here's another question. In these two cases, yeah, we gave TPA. Would we give aspirin or Plavix on top of TPA for or do we not? I mean, I don't know. I don't
I
know.
think so. Wait,
You do?
why
You
not?
do?
I think we wouldn't give aspirin if the stroke was probably due to any arrhythmia or any other cardioembolic event
Right.
or dissection. There is a very sensible topic, I think. There are many possible treatments for carotid dissection, but if the stroke is ischemic and the person, and you can find any other indication for anticoagulant, then you should give the person aspirin.
I see. Okay, because I didn't know if if you're gonna give TPA, then do you still need to also give
For secondary
Plavix.
prevention.
like loading, like you know how they give aspirin 325 and Plavix, they can load with aspirin and Plavix, and then they can give like the baby aspirin and Plavix. So I don't know if you would load or not. I kind of
You mean in the acute treatment for the first stroke?
Yeah, like if you're giving TPA, do you also load with aspirin and Plavix? I feel like that's a lot of antithrombotic. Yeah, I'll have to read the guidelines. I know sometimes, yeah, I know like if let's say this guy presented outside the window of TPA, is that then when you load with aspirin Plavix?
Mm-hmm.
Instead of, so that's something that maybe one of these cases will.
So I'm personally not familiar with the patient being loaded with aspirin unless they are doing a thrombectomy. I'm trying to go back to my days here, and I feel like that's I don't think they were loaded. I think that was more the loading of the clopidogrel or the of the aspirin was more of a thrombectomy situation. But I could be wrong. I'm not clear. Aspirin is so tricky, and it's interesting. They mentioned the whole aspirin situation even at AAN, like, and there's still some there's still some sort of debate. Do you give? Do you not? What about AFib? Da da da. And it's just so. I have to kind of go back to the guidelines. I'm not 100% clear on that.
Sometimes I never know when to do it or don't. So here's a cheat sheet that one of my colleagues did. I can share this with you guys. All medical trials and names. So let's see. So the East. Let's see, stroke TPA. So all this. So right now, I'm looking at all the stroke trials for acute care in the hospital. The patients with large proximal anterior occlusion. This is all intra. Okay, but we want aspirin. Thrombectomy. This is all thrombectomy. Okay, so carotid stenosis, patients for blood, 94%. Okay, that's stenting. Okay, so for TIA minor stroke, patients with TIA minor stroke, you can start aspirin or Plavix within 12 hours of symptom onset. Reduces the 9-day stroke incidence at cost of increasing bleeding risk when compared to aspirin monotherapy.
Is 81 milligrams equivalent or inferior or superior or whatever to 325? What dose are you giving with aspirin in this case?
So if you're gonna give aspirin and Plavix, you give the 81. But if you're gonna do aspirin monotherapy, I've seen 325. Okay. So I've never seen 325 aspirin and 75 Plavix because that's.
I agree.
Yeah.
It's if you're doing dual antiplatelet, and then by the 6 month or year mark, at some point you're going to end up being on monotherapy. I believe 1 year is the golden hour. But in cases where I for some reason I feel like I've read stuff where it was like 81 is equivalent to 325. But I don't know exactly where that I just recall it. So, but again, there's just so much debate with this whole aspirin, even the whole enteric coated actually it doesn't matter. It just delays the absorption, but you still get GI problems. So it's just like I'm noticing that people are starting to do less and less of the 325s. So Gabrielle is endorsing that because I think we're noticing we're not seeing any benefit to the 325. But again, I would like to see more research on the aspirin. I'm glad you brought that up.
Yeah. Let me know what you guys find, because I know that it's very at our institution, very attending dependent when it comes to the aspirin and the Plavix, and do you do 90 days versus 6 months versus a year? Mm-hmm. So it looks like. So if you have a minor stroke or a TIA, then that's when you start. Well, I guess for a TIA, you want to start TPA because it's because it's gone, like symptoms are gone. So minor stroke, you want to start TPA because we want an NIH. I just told you about we want an NIH rating 6. Okay, so then I guess those patients who are not candidates for TPA, then you consider DAPT or monotherapy. So if they present within 12 hours of symptom onset, then you can do aspirin or clopidogrel. And then the change trial says for single patients, you can start aspirin or clopidogrel within 24 hours of symptom onset. The latch says in addition to aspirin and clopidogrel, the patients with prior ischemic stroke or TIA did not reduce rates of recurrent TIA or CBA. Combination therapy confirmed to increase. So this is why it's conflicting.
Exactly. Yeah, so I think that's why there's this big discussion, like, are we overkilling? Because bleeding when honestly a little baby aspirin might just do the trick.
Yeah, sure, just do like 81.
I'm noticing that to be kind of like the new trend.
So, but it looks like we would never give aspirin, Plavix, and TPA at the same time.
No, okay. I'm gonna say that I haven't seen that personally.
Okay. Awesome. Let's see if this is anything else. Cool. We did it. Nice work. So that takes care of case 2. Let's see. We did all this. Case 3 and 4. Maybe let me throw some curveballs now. So a 65-year-old female who just finished a gallbladder surgery 3 days ago. She was last seen well at 10 p.m. before sleep. Wakes up at 2 a.m. and was discovered by her husband to have aphasia. So aphasia speech, if the patient's right-handed, then this would be the left side. And then right hemiplegia, so that matches. So left-sided right hemiplegia would be the left side. So she came to the emergency room at 3:15. She was last known normal at 10. So also she's past the window for TPA because it's been more than 4.5 hours. Okay, so she's not eligible for TPA because of her wake-up stroke and recent surgery. Oh, so for the recent surgery, I have to go back in.
I don't know if this particular surgery is a contraindication. This would okay.
Oh no, I was thinking the same thing. I'm like, it's laparoscopic. I don't know.
Well, and also, like, not all surgeries are equivalent. So
right.
I know for sure if it was any type of brain surgery, any type of neurosurgery, but let me just double check on my exactly TPA. So it was the major surgery or serious non-head trauma, and I don't laparoscopic. I mean, if there,
is this a major surgery?
Yeah, I'm like, no, laparoscopic is actually minimally invasive and also like relatively, unless she had massive complications, which most don't, this could very be a clean, so this is a same day surgery. This is an elective outpatient. That's of course if nothing went wrong. So I would not necessarily consider this as a major surgery. People walk out the building like this all the time. So I don't think that, I think the greater number of neurologists would probably say, hey, let's touch her.
Yeah, and I'm looking here on MDcalc, and you guys are all right. It says relative contraindications is major surgery or serious non-head trauma, and this is an elective, and it's laparoscopic, not they cut her open. Okay.
Yeah, it's not open, so and it looks like 3 days prior, meaning it looks like she went home. Like she really wasn't in the hospital. She did it, wham, bam, thank you, ma'am, went home. So
yeah, cool. So her NIH was 19, so we know she's not a candidate for TPA because of the window. So now the question is could she be a candidate for mechanical thrombectomy? So
can I just add something?
Yeah.
I just Googled definition of major surgery, and it says, according to Emory, major surgery is any invasive operative procedure in which a more extensive resection is performed. For example, body cavity is entered, organs are removed, or normal anatomy is altered. So I think, or in general, if a mesenchymal barrier is opened, pleural cavity, peritoneum, or meninges, the surgery is considered major.
So like body cavity, organs removed.
Well, that's, I guess that would qualify.
What was the last part?
Sorry?
You said body cavity, organs removed.
Yeah.
What else?
I'm gonna send you the link for you.
Thank you.
Yeah, but it's minor.
Debatable.
It's major, but it's minor.
Yeah. I guess debatable. Thank you. Debatable. So we do a CTA and it shows inclusion of the left MCA like we expected. And we see that there's reduced blood flow. Ooh, let's practice our arteries again. I know Gabriella loves arteries. Oh.
No, I need to learn
the
this.
ACAs there, right?
Awesome. And then what connects?
The ACOM there.
Awesome. And then here we have
the MCAs.
Fantastic. And then looks like
certainly is there on the left side there.
Awesome. And then what?
Would that be the PCA or?
Yeah. Here, if it was lower cut or a different cut, what would this be?
Would that be the oh my goodness, it's the superior cerebellar?
Cerebellar?
Wait, I need a cheat sheet.
Yeah, it'd be so what comes off what? The PCOM comes off the what?
The PCOM
yeah.
Comes off the PC.
Yeah.
Vertebral artery? No.
Yeah. Posterior cerebral artery. Because that's what's feed that.
Okay.
That's what feeds. Yeah, that's what feeds the like the occipital lobe. So PC. So posterior communicating is here. It communicates the anterior circulation with the posterior circulation, and then so we have the posterior cerebral arteries here, and coming off the basilar is going to be the superior cerebellar artery. Then we go down, and I know I'm no longer drawing this to scale anymore here. Then we keep going down basilar, and then we have the vertebrals that come off the basilar, and then lower down we have the anterior communicating artery, anterior inferior cerebellar artery comes off the basilar, and then we have the posterior inferior communicating that comes off the vertebral, and then here's a bonus. What's this? Yeah. Awesome.
And that is in the lateral area.
Lateral. ASA, lateral medulla. ASA is the what?
Wait, hold on. I messed that one up. It's actually in the medial. Sorry. Sorry. I had it straight. Sorry. It's in the medial medulla. My apologies.
Oh, it's all good. I'm just messing with you.
Yeah.
Awesome. Cool. Turn this off. So that's that. Here's a question. This actually came on my right exam. So the right exam is the exam that we do. It's kind of like our board practice, and we do it every year to see where we're at and see what we need to study, et cetera, et cetera. It's kind of like USMLE question bank, but for neurology residents. So this came up, and when do you do CT perfusions? Because I don't always see it done. And based upon the cases here, I guess you do it when it's a wake-up stroke. or when you're debating, do you want to do mechanical thrombectomy? How much per number is there really versus dead tissue? So CT perfusion study was done, shows hypoperfusion. So all the red is the hypoperfusion area, and we want to figure out, is this dead tissue or is this tissue that is not dead yet? Yeah, salvageable. So
neuro word.
salvageable. So let's see. So they do an angiogram, shows the left MCA occlusion. She was taken to endovascular suite. Mechanical thrombectomy performed. Tiki score of 3, which means complete revascularization. Ooh, let's practice our blood vessels again. Let me see if I can find my note. So this is the
Internal carotid?
that'd be my guess. And then, this would be the what?
Is that MCA or
Anteriors?
Yeah, I think this is the anteriors.
Oh, I see. Yeah, you're right. Those two.
Yeah, they are like
It's a weird
going
view.
up, right?
Yeah, because I feel like here's the nose. Here's like the eyeball, where the eyeball would sit. And then this is
view, right?
yes, yeah. And then this would be like the lateral part. This would be the top of the head.
Mm-hmm.
So then this would be the MCA, and then the ACA is like right here. Cool.
Why did they never have the view like on these imagings?
Because that would be too nice.
I just never understood that. It's like with X-ray, it's like it's AP or it's
right.
I'm just.
No, you're right. They should. Oh,
so right.
The letters. Hey, so it says the letters. I know sometimes they have like the letters for like right and left, but I would only be guessing if I thought that this meant anything. I don't know. Right anterior. I'm guessing. Let me just stop. Okay, so what do you think here? So
same thing what Gabrielle was saying, like those two going up now, ACAs, right?
Yeah. And then Yep, that's what I think too. Cool, awesome. Or maybe one's shown before and after, or am I making that up? I don't know. Maybe I don't know. Let me stop guessing.
No, there's definitely. Look at how much spaghetti is on the right.
Yeah. Oh, good call. So this is probably revascularization.
Yeah. So this was an MCA occlusion, right? So exactly, you're drawing the MCA, and look at all that spaghetti.
Yeah, you're right. Good call. Cool. Awesome. Look at us become a stroke neurologist. So proud of us.
Secretly, I want to do headache though, but okay.
Hey, there's a lot of headache and stroke.
This is true.
See?
Yes. Exactly. Although I love stroke, but I'm like, I don't know about this pager situation.
Right. I hear that. You're right. I have a colleague going into headache. She says, I never have to carry the pager again. And if there's a headache emergency, you guys are seeing the patient, and then they'll follow me in outpatient. It's like, and she gets her weekends off. I'm like, you don't have to rub it in.
I mean, listen, stroke is trust me, I love vascular stroke. It's like my baby, but like
no, I get it.
I'm getting up there on age, and I'm
enjoy that life, enjoy that clinic life. Okay, so now we're here at MRI.
Infarction. Wow.
Yeah, that's interesting. How did you not have any infarction? I guess maybe it didn't last. It didn't last long enough for it to show infarction on a DWI. I would have expected some infarction. Some dead tissue.
She probably was like, she was like older and had
collaterals.
More collaterals.
Oh, gotcha. Cool. Beautiful. Awesome. So case 4, 38-year-old male with left hemiparesis. So left-sided symptoms, thinking of the right side, go to the ED, telephone consultation with stroke neurologist. So this is like telestroke. He was given TPA, minimal time, 1 hour and 30 minutes at the onset. He was transferred to come here. Look, the dripping ship!
I know what it means.
I'm happy for you. Like, you're now gonna, everyone's dripping and shipping.
Now, NIH is 11 after being given TPA. They do CT head and neck, shows the shows it right. So yeah, left-sided symptoms are right. Very proximal M1 occlusion. Like he has, like if you look on the left compared to the right, dude has no blood flow going to that right side of the brain.
Oof.
Oof, you're right. CT perfusion. See, now I wonder why they did CT perfusion on him.
How, well, is it because it was such a large infarct that they're like, we don't even know what we can do? What's going on?
Yeah. What was his stroke scale? Who knows? I feel like I need to figure out when to do CT perfusions. I feel like some people do it, some people don't.
So my understanding also about the CTP, I'm glad you like brought that up. It's like not in like the stroke protocol guidelines. So like definitely on the more discretionary, like I kind of use exactly how you're saying, like, hey, we don't know what to do with you. And we're just gonna try to figure out what we can do. So we're gonna image the heck out of you, and you're not eligible for this. Your NIH is through the roof here. You're waking up stroke. Like there's just I just feel like a lot of people just get like the CTP when you're in that, like, we don't even know what you're eligible for. Like we're like, our hands are up in the air, like, so let's just see what's going on even more. So
that's a good point.
Yeah, makes sense.
Yeah.
I'm sending it's an algorithm from UpToDate where they summarize some of the trials that used these images that you were asking for in order to decide if the person is eligible to the mechanical thrombectomy. So it says that on trial and what is the other one? And diffuse 3 trial, they required some numbers for the ischemic core volume. So I think you probably do these images when you are thinking about doing a mechanical thrombectomy, but you're not sure. And then you need like a standard number to see if it's going to be useful for this person or not.
I see. So you would get the CT perfusion if you're doing mechanical thrombectomy?
Yeah, I think that's it. If you are considering and you want to know how much of the brain can be
like salvaged.
Salvage.
I see.
Drip and ship and salvage.
I see.
Yeah, if you go down this page, there is an algorithm in the left part.
I think I have to be logged into mine. But if you, let me stop sharing. If you're able to pull up the entire.
Okay. Oh, I am not a co-host.
Hold on. Let me change the settings. Still trying to figure out how to. Let's see. Okay, there you go. Awesome.
Yeah. Now I can. 1 moment. Let me find here. Can you see my screen?
Yes.
Yes.
Yeah, so that's what I was trying to say. Here they put the values that are important, like the infarct volume. And here as well, the ischemic core volume, and we got all of these informations, as far as I know, only with the perfusion imaging, but they have this whole algorithm here that I think it's very useful. So this person, I might be confusing the case, but I think this person arrived less than 4.5 hours, right?
Yes, yeah.
Yeah, and then we did the outer place. It was anterior circulation.
Mm-hmm.
Oh, I thought it was MCA. Or was it AC?
Or no, so interior circulation includes ACA and MCA and ICA.
Okay. Thank you.
And they divide in posterior and anterior. And I don't remember the time, I think, but if it's between 6 to 24 hours, you can do the perfusion studies and then analyze if it's worth it or not.
Thank you. I see. So 6 to 24 is software for automated available. If so, okay, then do.
So that would be. I'm kind of confused with the 6 to 24. So 6 to 24 hours, like the stroke was. What does a 6 to 24 mean, or less than 6 hours? What does that reflect?
Comparing to the time of the stroke, like for the TPA, it has to be less than 4.5 hours. But for mechanical thrombectomy, you can do it at the maximum of 24 hours after the scene well or the hour that the stroke occurred.
Okay, so essentially that's the imaging of choice prior to thrombectomy. Is that what is? Am I interpreting that correctly?
Yeah, that's my understanding.
Okay, gotcha. Okay,
like if the stroke occurred, sorry, you can go.
No, I think it just like clicked to me because I mean, obviously you've done the non-contrast CT and then you've done the CTA or MRA rather, which I feel like I see more facilities using the CTA. And then that makes sense now for the thrombectomy standpoint to do the CTP. Okay. Makes sense.
Mm-hmm.
Fair enough.
This is showed up on my brain exam. Hopefully I got it right. Might have been guessing. Cool, thank you. This is why I love these study groups, because now I come out be like, I know stroke that much better.
And the brainstem.
Same.
Yeah, and the brainstem. And I still gotta practice the brainstem though, but at least I knew him better than 2 hours ago.
Yeah, same.
Oh man. Okay, so let me go back to. We're almost done. Let's see. So now we see that they angiogram. Oh man, that person has no blood flow. So they do mechanical thrombectomy. This will be easy. We know the blood vessels. There's only just pretty much 2. So then mechanical thrombectomy with stent. So we see that they're trying to retrieve it in the right MCA. Oh, look, spaghetti! Like Laura said. Oh, this is why I won the stroke. This is so beautiful. Like, I see this in real time. Patient has like an NIH Stroke Scale of 20. You know, we do mechanical thrombectomy. Their blood vessels look so beautiful. And then you do the exam and then it's like 2. And it's like magical. Beautiful. That's why I was born in the stroke. It's amazing.
Are you considering endovascular?
No. I love my life. No. No. Nope.
Gabriella, what about you? Are you considering vascular or what area?
I don't know. I can't decide.
Like, do you want a life or do you not want life? I think that's the big question.
Yeah.
Do you want a pager?
No.
Okay, there it is. Full recovery, DWI shows diffusion in the basal ganglia.
Yeah.
Awesome. Let's see, case 5.
I might have to leave because it's kind of late here.
Yeah, that's true. We've been going at it for 2 hours. We can stop here. This is fun.
Yeah, it was a pleasure to be here with you. Hopefully I can make 2 more study groups.
Yeah, thanks both for
so
coming.
much.
And if you guys, I'll post another one tomorrow and we can just pick up where we left off and whoever comes to on. Cool. And if you guys ever want to lead a session, just let me know and I'll set up the group and we'll run cases together.
Perfect. Thank you so much. Bye.
Thank you, everybody. Have a great night.
Thank you.
Bye. Good night.
Bye-bye.
Good night.